This is the Ear Science Podcast, the science of healthy hearing. Hello and welcome to the Ear Science Podcast, the science of healthy hearing, proudly presented by Ear Science Institute Australia, a medical research institute. In the science of healthy hearing, we bring you into our world, the world of ear and hearing science. I'm your host, Dan Vandermeer, and first up, we acknowledge the traditional custodians of the land on which we are working on, the Whadjuk people of the Noongar Nation, and we pay respect to elders past and present. Now, whilst we're preparing for Season 3 of the Ear Science Podcast, The Science of Healthy Hearing, we thought we'd just do something a little bit different and drop something special into your feed. Coming up is a chat between Purple Pen podcast host Kristen and Lions Hearing Clinic audiologist Pia, who spend some time talking more about tinnitus. Tinnitus is very common and there's a misconception that nothing can be done about it. And whilst there is no cure, there's a lot we can do to help treat tinnitus. If you don't know who they are, the Purple Pen podcast is a podcast hosted by Kristen Zenos and Natalie Tasker. It's a podcast produced for, but not limited to, pharmacists and health professionals. Fun fact, it's called the Purple Pen podcast because purple is the pen colour of choice for hospital pharmacists. There you go. You can catch them via their website, purplepenpodcast.com, and there's a whole bunch of links to socials and episodes from that website. Check it out. And now, here's a very special chat that Kristen and Pia had about tinnitus. We hope you enjoy it.
Hello and welcome to the Purple Pen Podcast, a podcast for pharmacists and the people who work with them.
Okay, welcome back to our listeners. Today we are very lucky to have on the podcast a clinical audiologist, which is a first for us. So welcome Pia Nairn. Pia is a clinical audiologist, as I said. She works at the Lion Hearings clinics, which are under the umbrella of the Ear Science Institute. Welcome, Pia.
Thank you for having me.
Oh, it's wonderful to have you with us. And Pia, we're going to talk about a topic that is very close to your heart, I believe.
Yes.
Tinnitus. Which one is it? Is it like both work or one is more correct?
Oh, look, both are correct. I think the origin of the two comes from the east versus west coast of the US. But typically in Australia, we say tinnitus, but you're not wrong if you say tinnitus.
Okay, that's good to know. So I think a good place to start is, what is tinnitus? Because I think a lot of people probably have a preconception about what it is and what patients experience, and it's probably a little bit more nuanced than that.
Absolutely. So the definition technically of tinnitus would be basically the perception of a sound by an individual in the absence of an actual external sound. Often it's referred to as a ringing or buzzing sound, but the actual sound can vary quite greatly. I should also say there is another subset of tinnitus that is not that. It's essentially when you're hearing sounds your body is making. So you might hear your blood flowing, you might hear muscle spasms from the soft palate, eustachian tube, those kind of things. And they fall under tinnitus, but they're a different mechanism.
That sounds like very eerie and meta. And is that usually induced by funky substances or?
Sometimes, people who have congestion, you hear all the gross, clicking and clacking, but It's also a lot of temporomandibular joint type things going on that also affect the middle ear muscles and the eardrum as well. So, there's sort of two components to it. So, but technically when people talk about tinnitus, they're really referring to that ringing or buzzing type tinnitus.
And can you talk us through what the actual mechanism is? Because I think people think that, as we've said, you hear a sound, but what they might not understand is what is actually causing that sound. It's not something that a person is really hearing.
No, that's right. So, as far as the brain is aware, there is a sound there. And the reason for that is it's coming from spontaneous neuronal firing somewhere in the auditory system. So whether that arises at the very cochlea or somewhere further along, the auditory nerve, brainstem, midbrain cortex. But the point is that signal gets to the auditory cortex and the brain perceives it as a sound of some kind. And the cause of that onset varies from person to person.
Yeah. So let's get into some of the causes of
Yep. Well, so the most common cause of tinnitus would be like natural wear and tear of the ear causing a hearing loss. So that might be through age, noise exposure, some chemicals as well. Basically, any sort of injury or insult to the ear can also cause it. But it's essentially the lack of normal stimulation of the ear in these cases. So the cochlea is not getting input, and so there's this spontaneous firing at certain places along the basilar membrane and the auditory nerve that's connected to those regions that then goes up to the brain. So noise, age, head injury can do it as well, because that will cause, more central tinnitus as well. It's such a heterogeneous sort of population, but if it causes a hearing loss, typically it'll cause tinnitus. And then you have other things that will cause exacerbation of tinnitus, which I think, so there's these two populations. So there's a population of people that have tinnitus who it doesn't bother them, and then you have this population of people with tinnitus and it does bother them, and they're the people who, as audiologists, we see a lot of as well. Yeah. Does that sort of answer?
Yeah, definitely.
Yeah.
And I think this is probably a bit of a tricky question given the completely, as you said, heterogeneous group of people we're talking about. Do we know how common it is? And I imagine it's kind of hard to quantify that, because for some people it's transient as well.
Exactly, yeah. So one of the things that I always like to tell people who come in to see me about tinnitus is there was this experiment done in I think it was 1950s, 1960s, and they got a whole lot of people with perfectly normal hearing on the audiogram, never reported any tinnitus, and they put them in a soundproof booth and said, let me know if you hear anything. And after 20 minutes, over 90% of these people reported hearing sounds. So, in certain situations, even a normal healthy ear is going to experience a tinnitus, which is why it's so hard to quantify how many people actually have it. So if you look at all the studies that are done, it's really how they define that tinnitus. So is it presence of tinnitus? Is it presence of chronic tinnitus? Is it presence of bothersome tinnitus? But a recent study came out, a Western Australian study, that said that 1 in 4 of the working Australian population have tinnitus, and usually, from mild and above. So it's really quite prevalent. The more distressing cases of tinnitus, where people really are seeking help and it's really the, primary concern in their life, would be maybe about 2% of people who have tinnitus. Okay. So, it's quite, you're quite right. Like it's based on the definition of whatever study you have, you're going to get different presence or, demographic. Yeah.
So what it's sounding to me is like the brain really craves input in the form of sound. And when it doesn't have it, it's like, well, I guess I'll make some up then.
Sort of. And I always talk about that hearing as, our auditory system, it's our security system, right? So if the brain's not getting input, if we go to sleep and we can't hear anything, our brain is like, what's going on? That's a pretty artificial environment. So, just like when you're in the dark, your pupil will dilate to get more light in, your ear actually has mechanisms to try and increase the sensitivity of your ear. But if you have a hearing loss, you have more of this spontaneous firing anyway, and the brain actually then turns up your tinnitus in quiet as well. So, it's the brain really trying to hear. You're quite right. It needs that sound in order to essentially feel safe and in touch with its environment. So tinnitus often comes out as a byproduct of that as well. Yeah. Just the compensatory mechanisms that we have.
You touched on before about like the different severities of tinnitus, and is there any kind of international agreed upon criteria for defining it, or are you just kind of mild, moderate, severe? Is each person doing their own kind of assessment?
It's a little bit like that. I mean, there's some sort of validated questionnaires that we use. So the one that most commonly used in my various roles has been either the Tinnitus Handicap Inventory and the Tinnitus Functional Index. And what they're looking at is, the assumption is they have tinnitus. That's why they're completing the questionnaire, but it's how much is it impacting them, and then it's the impact that's then rated mild, moderate, severe, catastrophic.
Okay.
And it normally looks at all those lifestyle factors, is it affecting sleep? Is it affecting relationships? Is it affecting hearing? That kind of thing.
Yeah. I'm glad you mentioned that, because what I was hoping you could give us some insight into, as you would have encountered many, many patients with this, is what the experience of tinnitus is, because I think some people can trivialize it. More and more as a society, we're developing an appreciation for what they classify invisible disabilities.
Yeah.
The disabilities that aren't necessarily obvious when you first encounter someone, but tinnitus can actually have quite a significant impact on somebody's quality of life.
Absolutely. And I think the thing is as well, because there's so many people who have tinnitus, and the technical term for it is they've habituated to it. So they're very cavalier about it. They're like, oh, just get used to it. It's, it's nothing. I've got it. I just ignore it.
Yeah.
But then there's these other people who, they live with it every day and they can't ignore it. It can be on a milder spectrum. It can be as long as they're busy, they don't hear it. But the second they try and relax, that's when they do hear it, and it impacts just their relaxation time. Or they just hear it when they're trying to sleep. But, if it's a more severe case, even if they're trying to concentrate at work, they're trying to do something, there's this constant sound there that's distracting them and grabbing their attention. And it can be really exhausting as well. Trying to block out this sound can be very stressful. And then also if sleep is impacted, their day-to-day functioning for concentration is diminished as well. And also that resilience as well that we, in order to cope with these things starts to diminish.
And it would take like a huge amount of energy on that individual every day that...
Yeah, and the prospect that it won't go away, it's like, it's quite unpleasant experience for them.
And I mean, that prospect is interesting as well, because you mentioned before the concept that a patient gets used to it. Mm-hmm. Can you tell me a little bit more about that, with the consideration of like the natural history of tinnitus? Does everybody kind of get used to it? Or for some people, is that intensity always kind of there?
Yeah, so I mean, the majority of people over time will habituate to their tinnitus. And, that habituation is that, no longer responding to sort of a sound or a stimulus that's always there. What determines whether someone habituates to their tinnitus is how the brain is processing that signal. So if you develop tinnitus, particularly if it's just a gradual onset, as that, your hearing might slowly decline, the tinnitus might become a little bit more prominent. Generally, they habituate quite quickly. But for someone who has a sudden onset tinnitus, when that sound commences, you have a very strong stress response with it. You've had a medical, this medical issue has impacted you, and there's a lot of worry and a lot of unknown. And that stress itself is what triggers the persistence of that signal, because it's how our brain labels things that are important. So if you never get that peace of mind and have your, concerns ameliorated, often the tinnitus will persist. So it's, if you don't seek help, essentially, you don't have successfully sought help, often the tinnitus will persist. The other thing that we do see is you might have tinnitus for many, many, many years and you've habituated to it, doesn't bother you. And then there's something in your life that happens that triggers a stress response, and that same tinnitus that never used to bother you, all of a sudden you can't ignore. And the tinnitus itself might not have changed, but your physiology has, and the way the brain processes sound has changed. So, again, you get these peaks and troughs in awareness with cycles in your life. As a stressful event occurs, it can become more prominent. And often we find when all that calms down, often the tinnitus perception will calm down again as well. So it's never this static thing on off. And sometimes like the tinnitus will be there. And then there's people who have habituated. If they listen for their tinnitus, they always find it.
Yeah.
And if you have that attention, if you're constantly looking for it and symptom searching, do I have coffee? Does it make it worse? You listen for it. The tinnitus doesn't go away because you haven't drawn your attention away from it as well.
Yeah. Just from my initial conversation with you, I'm getting the insight that a lot of your conversations with patients who have tinnitus is about socializing them to a lot of these concepts and kind of talking through a lot of this stuff?
Yeah, like a lot of what we do is informational counselling to make them understand the processes. One of the things, like I always say from the outset, is technically there's no cure for tinnitus in most cases, unless there's obviously like a medical reason for it that can be, treated. But everyone with tinnitus can be helped. And that's the most important thing you can tell someone, is that there's hope. And when you have hope, immediately those feelings start to
I feel like it just
back.
the stakes become lower for somebody.
Absolutely. And quite often you'll have someone who's gone through this whole process of getting it checked, and they get told you just have to live with it. But they don't get given any strategies to live with it well, you know? And that's the big thing. And that's where the audiologists often come in.
Or even just like contextualizing for them, as bad as this is now, there is every good chance that it's not going to remain at this level for you into the future.
Exactly. But again, there's no guarantee. Yeah. So, you have to be careful with that. But certainly there's a lot that can be done. And if they follow your recommendations, often, the majority of people who come to see us, then the outcome is they're at least in a better place. Their tinnitus might not have gone. It's usually a very long process for tinnitus to habituate. But yeah, certainly teaching them about their tinnitus and then teaching them strategies to manage it. And also one of the big things is highlighting the behaviours that they're doing that are contributing to its persistence as well. Yeah, that's a big one too.
So given that we're a pharmacy podcast with a lot of pharmacy listeners, thought I'd drill down into some of the medications aspects of it. Do we know if any particular medications are well known to aggravate tinnitus as a trigger?
It's a tough one. So for example, aspirin is known to increase tinnitus, but the dosage in which you would have for that to happen has to be so high, it's not like a normal dosage. But there's obviously a few people who are more sensitive to aspirin that have experienced tinnitus exacerbation. But the other thing as well is, if you're doing a clinical trial on a medication and someone says, they're looking at all their symptoms and they're listing them, their attention to what they're experiencing, that they typically will list tinnitus. So a lot of them list tinnitus, but it's actually not necessarily
a causal relationship.
Yeah, but they have to put it there because they mention it. So definitely aspirin is known. Then there's all the ototoxic medications that would be a trigger for tinnitus. So all the
aminoglycosides,
exactly, and like chemotherapy agents as well. Is if you're creating a hearing loss, you may cause tinnitus. There's a few drugs as well that, sorry, I'm going on to the cause, that make tinnitus worse. The loop diuretics can cause tinnitus to change as well, because a lot of the same channel, sodium potassium channels in the kidneys are the same as in the ear. So if they affect the kidneys, they affect the ear. But usually I think that's a temporary one unless it's a very high dosage as well. Yeah.
And what about medications recommended for tinnitus, kind of with the lens of the kind of evidence level associated with them?
Yeah, I think currently there's nothing that's actually been approved for tinnitus. And again, that's that heterogeneous population. There's evidence to show, so say if you have tinnitus and depression, antidepressants help a lot with tinnitus management. Again, that's getting that stress response under control.
Yeah, so rather than actually helping the tinnitus, it's helping the baseline physiology that might be causing you to focus too much on the problem.
Exactly. I have seen people be prescribed benzodiazepine as well, because that does have an impact on some people's tinnitus, but it's not like a guarantee. I think they
also like super tricky to kind of promise that as a long-term management plan.
Exactly. Yeah. So it's better to, the management strategies as audiologists, we're basically trying to get people to that habituated state so they don't need to medicate to manage their tinnitus. But I know they've tried there's a lot of clinical trials that have happened, tried like anesthetics, lidocaine, anticonvulsants as well. And that's that idea of that excess excitation of the nerve, trying to get that excitation overactivity down. But again, nothing has made it, to the point where it's like, this is something we would recommend as a go-to.
Yeah.
Yeah.
And what about some of the non-pharmacological therapies for management?
Obviously, mental health is a big one.
Yep.
So we would, if they haven't already been under the care of a psychologist or a psychiatrist, if we feel on discussion with them that they benefit from it, we would always recommend that they do that. But certainly, if someone has tinnitus, they need to get their hearing checked to work out, what is the potential cause of their tinnitus. Is it something that can be referred to a specialist, like if it's wax occlusion even, or something to do with the middle ear, they might actually be able to have a procedure that improves it. And then if someone has just a typical sensory neural hearing loss from, again, age, noise, hearing aids actually are very effective at managing tinnitus because they're stimulating those parts of the ear that aren't getting sound. So a lot of people find they suppress their tinnitus when they're wearing them, or at least partially suppress it, mask it, making it easier to cope with. And likewise with cochlear implants, it's a bit harder because the cochlear implant, sometimes it can trigger tinnitus. Like, it depends a little bit on the individual. We probably wouldn't be guaranteeing that it gets rid of tinnitus, like you would perhaps recommend a hearing aid because that's reversible.
Yeah.
Cognitive behavioural therapy has been probably one of the most widely researched management strategy for tinnitus, because it's quite a well-known one. There's been a lot of trials and it is effective, but it takes a lot of time as well. And then I guess a lot of people talk about sound therapy, masking, but that's sort of in conjunction with, if there's a hearing loss, hearing aids are part of that. But if there's very mild hearing loss or normal hearing, it's kind of that same concept of sort of stimulating the ear to reduce the perception of tinnitus so that you can habituate more easily to it. So there's a lot of evidence that they work as long as the individual is on board with the plan and sort of does it as recommended. If you mask a tinnitus completely all the time, you don't habituate to it.
Yeah.
And that's the thing. You have to be able to hear it, to retrain the brain to ignore it. And so it's how you implement it that's important. Otherwise, it's like a crutch. You might be able to suppress your tinnitus, but you're not making yourself move into a better situation.
Definitely. Thank you for that, Pia. I think that really kind of encapsulates the tinnitus kind of spiel, if you will, that I imagine you give on a very frequent basis.
Yeah, they're long appointments.
Yeah, I can imagine. I can imagine. Now, satisfying my curiosity, Pia, as a pharmacist who probably doesn't talk to an audiologist very often, I'm going to shoot a couple of just overarching audiologist questions that I imagine some pharmacists are probably curious about, because we do kind of, just the other week I was in community pharmacy working a shift and a person came in, hearing loss, no recent history of swimming, didn't really think it was a wax issue, and I was like, oh, you better go get your hearing checked. And I suppose really in our patient's best interest, we should really know what that means, what that involves, what happens to the patient next.
Yeah.
So if I say as a pharmacist, go get your hearing checked, do people need a referral from their GP? Does it make it cheaper if they go and get a referral to see an audiologist?
Yeah, so you don't need a referral to come see an audiologist, but with the new changes to Medicare, we now are able to, if we have a referral, you can claim back from Medicare a portion of that cost now, which is really, really good. You used to have to come through a specialist, so that's been a win for audiology and for people who want to see audiologists.
Oh, okay. So like as in a GP can now write a referral as opposed to a
ENT.
Yeah. Oh, that's good.
Yeah, it's really good. The other thing is if someone's a pensioner, they're entitled to free hearing services under the hearing services program. So they wouldn't have to pay at all for that hearing test. Same for DVA Gold Card holders as well. They can get free hearing assessments. And then also if, they do have hearing difficulties, they are entitled to subsidies under the government system as well. So that's really good if you have someone who's a pensioner, DVA.
Yeah.
But yeah, certainly if you don't want to go see a GP, because again, you have to sometimes pay to see the GP, it might not save you that much money to get that referral. You can just come straight to
depending if your GP bulk bills or anything, and if you can actually get in to see them.
Well, that's right. So but I would always encourage them, if someone's booking in to get a hearing, maybe don't say hearing check, because often a hearing check will be booked in at some providers. It's like a screening. You really, if you're concerned about your hearing, you should really push for a full hearing assessment.
Okay.
Yeah.
And is that kind of, just to get in some to the nitty gritty, so the differences between, there's a difference between, as I understand it, an audiologist and an audiometrist.
So the difference there is, so an audiologist is a 2-year master's. An audiometrist, it's usually, I think, 12. It depends. Like they can do it in a different time scale, and you don't need to have the bachelor prerequisite. But both of them are highly qualified. If you need a hearing test, both of them can do a great hearing test. The difference would be that audiologists have a lot more training on, like the pathologies.
Okay. So like in terms of like the next steps for the patient and what do your results mean, the audiologist...
An audiometrist would still, and there's some great audiometrists.
I mean, no shade.
There's a lot for a hearing assessment, there probably wouldn't be any difference probably between an audiometrist, audiologist. If they are an audiometrist and someone has a particularly complex hearing loss, they usually have an audiologist that they can work with. That's a requirement under the government system that they have that. So for someone booking in, you could do either, and they're both just as proficient at performing the test. Audiologists just also get that training in like pediatrics as well. We just get that extra layer of training, I think.
Yeah. And in terms of like, you'll see now as you're walking through a shopping centre, there are kind of hearing checks left, right and centre. They're in optometrists. They're kind of in all kinds of different places. In terms of the sensitivity of those for hearing screenings, as opposed to obviously a hearing assessment, which is a proper, involved process, how sensitive are those kinds of quick checks and what are your thoughts on them?
So, if someone has no concerns about their hearing, a hearing screening is perfectly fine. It will give us an indication of, do you need a full assessment?
From my kind of perspective as well, like there is a consideration that even if they're not perfect, but they're accessible and in people's face, and they think to themselves, well, yeah, I've got 10, 15 minutes of my time and I'll get it done. And otherwise I probably wouldn't have made the opportunity to.
Yeah. It does keep it on people's minds, which is important. It's one of those things that a lot of people... like everyone goes to get their eyes tested, even if their vision's not too bad, but the hearing gets a bit neglected until something goes wrong.
Yeah.
So it is good to just have it in people's minds, because it's such an important sense. We're very social creatures. When your hearing does go, it's a very profound impact that it has on an individual. So we want to keep it in the forefront of people's minds. And so hearing screening is very effective at just, keeping tabs on it. But if a person legitimately has a concern about their hearing, some sudden changes, they really just need to skip the screen and go straight to the test.
Yeah. And how long does a test usually take for a proper assessment?
It depends a bit on the hearing loss. So if someone has normal hearing and, they're young and quick to respond, a hearing test can be done, a comprehensive hearing test could be done in 15, 20 minutes. If someone's a little bit older, has a more complex hearing loss, it can take, up to half an hour maybe. And that would be including like all the standard, inclusions of testing. So I don't know if you want detail on what's
probably like obviously at a little bit more of an accessible level, what are some of the tests that might be done and why are they done? So I imagine different tools for checking different aspects of hearing.
Absolutely, yeah. So the standard test battery for someone who's just coming in for a hearing test is obviously we look in their ears, so otoscopy, and that's to check firstly for wax occlusion, because there's no point doing a hearing test if they've got any wax.
Ding, 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 ding.
Yeah, because you will find a hearing loss, so you may as well get the wax removed. We're also looking at the health of the eardrum and the ear canal, is there a fungal infection, that sort of thing. And also any pathologies of the eardrum itself, like cholesteatomas and that kind of thing. We'll do a check of the middle ear status, so tympanometry, which looks at the mobility of the middle ear system and the pressure within the middle ear. So a bit like, when you're on an aeroplane, you have to pop your ears. Some people aren't very good at popping their ears, and it can cause issues with their middle ear and hearing. So we measure that. And then we've got the pure tone audiometry. So that's the push button test, where we're looking at the hearing sensitivity across a range of frequencies. So the standard range would be 250 hertz up to 8,000, and that's where the majority of the speech signals are. And you would do air conduction, which is normal headphones, and there's a second headphone that would sit behind the ear that checks just the cochlear hearing, and that would be, if someone's got a conductive hearing loss from middle ear effusion, that kind of thing. That's how we sort of do that, how we distinguish between those types of hearing losses. In some cases, in particular with tinnitus, we'll also do high frequency audiometry. So often you'll find someone with normal hearing through that range, but then up in the high frequencies up to say 18,000 hertz, that you can see there's a hearing loss there that would explain their tinnitus too. But that's not part of the standard.
Yeah, so that's kind of like if the initial tests indicate there might be an issue, you pull out the kind of next level of tests.
Or if everything comes up normal and we're like, well, let's delve further, what other equipment do we have?
Yeah.
We might then look at the ultra high frequencies.
Yeah.
For normal assessments as well, we'll always do speech testing. So it's much more of a functional test of, yes, you can hear a beat, but can you discriminate speech?
Yeah,
and
hear a word, kind of the difference between seeing like a G and an O on an eyesight test.
Yeah, rather than can I see or not, Yeah, so we do a speech discrimination test in quiet, and normally you'll do what we call, so it was sort of looking for the max performance. So how good can we get in quiet, and we'll do each ear separately. And that's also how we determine whether someone's eligible for a cochlear implant, because if they're not hearing well acoustically, will they do better with an implant? And we also use the speech scores to validate the audiogram as well. So is it consistent? So that's how we might pick up malingerers and things for work. Yeah. Work assessments and whatnot. And generally, not all clinics do it, but I know with Lions we do a speech and noise test as well. So that's that other layer of speech recognition in a busy environment.
With like background sound and things.
Exactly. Sort of replicating that cafe noise sort of situation. And then there's a bunch of other tests that we can do as audiologists, like eustachian tube function tests, otoacoustic emissions, which is a cochlear assessment. But not all clinics have those equipment because they're quite expensive. So it's not part of the standard test battery.
Okay.
The eustachian tube function is, any audiologist could do that, and we do that often for diving assessments and things like that. So,
okay, that's interesting.
Yeah.
That is that for people who are planning a diving trip and want to make sure it's not going to cause a problem?
Yeah, so it's normally people going for their diving ticket who have had issues equalising in the past, and often the GP will, because they have to get their medical clearance to do it typically, the GP might request it to make sure they're able to equalise so they don't perforate their eardrum, essentially. So, yeah, it's just to...
I didn't think about that as a potential subsect of patients of yours, but it makes sense. Yeah. I thought we could finish off, Pia, with kind of like top tips to consumers, patients, the general public about, caring for our hearing more generally. We know about teeth, we know about flossing, brushing our teeth, all the rest of it, but I feel like we don't kind of have those top tips for hearing protection more generally. And I think we're, as a society, doing more things that can potentially damage our hearing, like headphones in our ears all the time. Is there a better way, like over the ear, in the ear, or is it kind of not really known?
Well, it's definitely been shown that the in the ear... Well, I mean, as an individual monitoring your own, noise dose, it's a bit easier. But say if you have children, that's sort of where the big concern is, like what noise dose is my child getting with their headphones? Yeah. So typically with the in-the-ear ones, there's research showing that the sound level that they're getting is really quite high. So the recommendation is if you can do over the ear headphones, it's going to be better. It's less direct and sort of pumping down the ear canal. But to be honest, the best thing is to have it in a free field, like speakers externally. If you want to listen to music all day, that's a better way to do it. It's just not always possible, but then over ear headphones are going to be better for you than in the ear ones.
Yeah.
But if you're wearing them, if it's loud, right?
Yeah.
And the whole thing with noise exposure, we talk about time intensity dose. So if you've got it in all day at a low level, you're fine. But if you have it in all day at a high level, you're risking hearing loss. And likewise, if you want it high, you have to shorten that time period of exposure or have breaks, that sort of thing. A general rule is, if you can hear someone's headphones and you're not wearing them, it's too loud. Yeah.
That's a good rule. Any other kind of general tips? Like the other one I can think of is, if you think you have wax, don't go digging for it yourself.
And I bet, because I know as pharmacists, there's a lot of products for, wax softeners and things like that. So a lot of clients come to you asking about that. But the reason we say don't sort of go digging around in there is if you have a big lump of hard wax, you're going to stick it right into your eardrum. So because you can't see what's in there, you really shouldn't be poking around in there. Just keeping things out of the ears is the best way. What I usually say to people, if you're worried and you've got a GP visit coming in, just get someone to look in their ears, get them to have a quick peek and tell you if there's wax, but you shouldn't really, like the ear self-cleans in most cases. So you shouldn't have to actively manage it unless you have a particularly winding ear canal or a particularly narrow ear canal or, psoriasis or something like that going on, which is added to the wax, it's skin and wax. Yeah. So my general recommendation is you shouldn't do a daily, cotton tip in the ear. You might just have a shower, get your towel and, dry it off, but not stick anything down the ear canal.
Yeah.
But if you are prone to wax build-up, which certainly with more and more people wearing things in their ears, that could become more common because it stops the wax coming out naturally. Yeah, get someone to look in the ear before you start, self-managing it. Yeah. I would say. Yeah. Yeah.
Well, I think that's all we have time for today. Thank you very much for coming on the podcast, Pia. It's been very enlightening and all the best.
Thank you very much to Kristen and the team at the Purple Pen Podcast and to Pia for being a part of this very special episode. Make sure to keep an eye on your feed because we are coming back with Season 3 of the Ear Science Podcast, The Science of Healthy Hearing. So stay tuned. Until then, thanks for listening and we'll be back soon. If you've enjoyed this episode, let us know by rating and reviewing this podcast or sharing it with friends and family. Be sure to subscribe so you won't miss an episode. To view this episode as a video with captions, visit the Ear Science YouTube channel or our website www.earscience.org.au/podcast. To suggest a topic for a future episode, links to more information and all the research papers on this topic, visit our website www.earscience.org.au/podcast. This podcast provides information of a general nature and does not constitute medical advice. The producer of the Ear Science Podcast, The Science of Healthy Hearing, is Emma Ireland, with sound engineering and editing by yours truly, Dan Vandermeer.